Hello, I'm Matthew Balti with the Acoustic Neuroma Association. I'd like to welcome everyone to today's ANAwareness Week presentation of surgical overview and what to expect with Dr. Rick Friedman and Dr. Mark Schwartz of UC San Diego Health. We'll begin shortly, but first, a couple of quick items. Captions are available for this presentation at the bottom of your screen. This presentation is part of our ANAwareness Week, so make sure you stay connected to the ANA through our social media pages on Facebook, Instagram, Twitter, and LinkedIn. Also, make time to visit our website, anausa.org, for up-to-date information on Awareness Week, view resources and videos, study clinical trials, connect with others, and more. A special thanks to all of our medical partners who helped make this week happen. Now, Dr. Friedman and Dr. Schwartz, if you'd like to turn on your camera and introduce yourselves, we can get started.
Hi, this is Mark Schwartz, and my name's on the screen just because this is my office, but I'm here with Rick Friedman. Rick?
Hi. Hi, everybody. We look forward to hoping to answer some questions.
And let's share the screen. Alrighty, presentation mode. So we're just going to go through the basics of, frankly, surgery for acoustic neuromas. Obviously, we all know that there's options for many patients, although for some patients, especially with large tumors, really surgery is the only option. But we're going to really focus on the surgery here and not talk about the really big first decision of how to treat particular acoustic neuroma, which of course is really the biggest question. When we talk about surgery, we then think about what are the most important details before really getting into the weeds. And there's really three main ones, I would say. The first one is where will surgery be done? Second one is what surgical approach? And then the last one is how aggressive are you with resection of tumor? Aggressiveness basically just means, where do you stop taking tumor out? Is your goal to get every little last bit of the tumor, or to really not try to come anything close to that? We're getting into some detail about all three of these issues. So where do you want to have your surgery done? There's many places across the country that are doing acoustic neuroma surgery. Each has a particular difference in terms of their philosophy, their volume, their experience. Nothing can guarantee results. So there's no way to absolutely assure that everything is ideal at the outcome of surgery, but you want to make sure that you put the odds in your favor as best as possible when you treat these tumors. And we're going to get into that a little bit. And then the other one is every place is a little different in how they think about things. When we treat acoustic neuromas, we're treating somebody for a lifetime. How you do the week after surgery is probably not the most important question. The more important question is how you get along with your life in the weeks, months, and years, and decades afterwards. It's hard for us to know in great detail with a lot of good data about the further and further you get out from surgery. We're also talking about quality of life, and a lot of that is very subjective and hard to put a number on. And so in addition to the data, we're all very careful with making sure we understand what the literature shows and what our results are. But we also take our own point of view from that and from our own experience to determine how we treat patients and how we think about patients and how we think about acoustic neuromas. And so it's important to understand that that's different from place to place.
Yeah, I think this slide shows pretty well that there is definitely an association between surgical experience and time in the hospital. So I think the both of us would say, and most people in the field would say, that your best chance of a great outcome is at a center that has high volume, something you should investigate. If you don't have a high volume center near you, we absolutely always recommend that you should get multiple opinions.
And another one of our publications showing that patients who travel and go to high volume centers have a better outcome than patients who stay close to home and go to low volume centers. And the bottom graph actually shows, frankly, mortality. So we're talking about serious surgery here, and understanding that you should want to be treated in a place that sees this on a frequent basis and makes this as routine as possible, as opposed to something they see very rarely. I think it makes total sense if that's the case. I mean, the higher the volume, the better the outcome. On average, by statistics. Obviously, nobody can guarantee outcome in any individual patient. We can only look at our volume to show overall how we're doing. And then the other point is philosophy. I mean, Rick, what do you think about our philosophy and philosophies of other centers?
Yeah, I think that, in the modern area of MRI scanning, we're seeing tumors that are smaller. So, if we see a patient with a large tumor or somebody who's very symptomatic, then it's an easy decision. We would recommend surgery. Our philosophy differs from a number of other places in that Mark and I have been working together for over 20 years. We've done hundreds of middle fossas together. So, if a patient is seeking a center that is willing to operate on a small tumor to try to save hearing, we most often can oblige them. Now, it's not a guarantee that we'll save hearing, but our hearing preservation results are really quite good. And so I think that's the philosophical difference between a high volume center with experience in hearing preservation than some other centers across the country. We give that option.
Yeah, and I would say I think that we sort of divide our patients into two groups. I mean, there's the first group of patients who typically tend to travel, tend to have a couple of opinions before they talk to us, and are seeking surgical treatment of their tumors, seeking preservation of function, seeking preservation of hearing when that's possible. And then there's also our local patients. So because we have a big program in one city, we see a lot of patients as the first center that they're seeing. They're coming in much more naive. And I think we have to start at an earlier point in those patients and say, okay, where is this patient coming from? We have to really have the philosophy of thinking about all the options and providing a balanced viewpoint of everything that can be done. I think we have a reputation of being surgically aggressive, which is the case for the patients that travel to us, with really asking, for what can we do surgically. But we see many local patients, and frankly, I think that we observe the vast majority of those, and are much more selective on how we treat those patients.
Yeah, I don't think we're particularly necessarily aggressive, although we feel very comfortable with our outcomes. But as Mark is saying, we get patients coming to us from all over the world, and those are patients that have had a couple of consults and have decided that they want surgery. So the population that comes from out of town is sort of unique. The other thing I just want to mention while we have this slide up is we very frequently get questions about, oh, if I travel, is that safe, et cetera, and plane flight. And the answer to that question is yes. It is very rare. So we have been doing this again, like I said, together for 2 decades. And so we have enough data to know that empirically, if patients stay a full 10 days, the likelihood of them needing to come back or additional care is pretty low. It's not zero, but it's pretty low. And so it is safe to travel.
So the next question about the details of surgery is what approach. And there's really 3 standard approaches for acoustic neuroma resection. I'm sure anybody who's looked into this at all understands this. We're going to go through this in a little bit of detail. This is not the purpose of this is not to really teach all the details of these approaches, but just to point out sort of when they're useful, why we would use them, and what patients should expect in terms of what the advantages and disadvantages of each. Translabyrinthine is a hearing destructive operation. So we basically approach tumor directly. through the inner ear structures, and so there's no chance of saving hearing. I would argue, and I think it's our experience, and that other than hearing, there's tremendous advantages to translabyrinthine surgery. Middle fossa surgery, which is for very small tumors trying to save hearing, and then retrosigmoid, which is a more generalized standard approach where hearing preservation can be a goal, and it can be useful for tumors that are sort of any size, but we would use it typically for more medium-sized tumors. This is not our picture, but I think it shows everything as good as any diagram I've ever seen in terms of what the three approaches are to the acoustic neuroma. The big blue structure that you can see ghosted in through the skull is the venous system of the brain. So, and it's a large vein called the transverse and sigmoid sinuses. We say sinus, and people think about air spaces when you hear the word sinus, but this is a venous sinus. So it's a big vein that we've got to work around. Go either in front of it or behind it. The translabyrinthine is in front, right through the mastoid, which is the bone behind the ear. The retrosigmoid, it says it in the name, retrosigmoid, which is behind the sigmoid, which is next to the cerebellum. And then the third approach, which is the one on top, is the middle fossa, which goes under the temporal lobe from above to get to the tumor. We're going to go through each of these in a little bit of detail, but not too much detail, to point out the pros and cons of each. This is just the model that I found from the stock photography of somebody with no hair, so we can see what the incisions are. Translabyrinthine incision is behind the ear like this, is not very large, and we work right through the mastoid to get to the tumor. We actually don't have to go really through much muscle to get there, so it's, in addition to being a direct route to the tumor, it's really least painful and least difficult to recover from. That's maybe a minor consideration compared to lots of other things, but it gets us directly to the tumor without disrupting things. This is what the incision we would make with middle fossa surgery, which is mostly above the ear, because we go through the skull to get under the temporal lobe. Now, we don't look at the temporal lobe because we're working on the outside of the dura, which is the lining on the inside of the skull, to approach the tumor from above. In terms of what this means with the scalp, we do have to raise the temporalis muscle, which is one of the chewing muscles. So patients frequently will complain of a sore jaw for some time after surgery, mostly opening the mouth, and like eating a big fat sandwich might be out of the question for a while. Other than that, there's very little soft tissue pain or difficulty in terms of that. And then the retrosigmoid approach is from further behind the ear. We go behind the sigmoid sinus and open up this incision. But it is sort of on the bottom of the skull. I'm going to leave presenter mode so I can actually point to a few things here. Our opening in the bone is sort of right over here, and we have to elevate the muscles on the bottom of the skull, sort of we call these the suboccipital muscles, and there's a little bit more pain involved with that. We actually tend to make a little bit bigger incision than we might have to in terms of the scalp. But the reason for making a bigger scalp incision is to be able to handle these muscles in a better way to create less pain, because really the scalp doesn't cause a lot of pain, it's the muscles that cause pain. There are a few nerves here that are involved as well. This small nerve is a sensory nerve called the lesser occipital nerve. I think a lot of people have some scalp numbness after surgery. This is true also of translabyrinthine surgery, because it's pretty close to that. Translabyrinthine opening is going to be over here. Retrosigmoid is going to be down here. But I think the more important nerve, which you can't see all of it, is the greater occipital nerve, which goes through the muscles down, coming out of the top of the spinal cord over here. It's also mostly a sensory nerve, but people can have a lot of pain and difficulty if this nerve is injured. That's why I really make a larger incision than a lot of other people make, so that we can elevate these muscles together and avoid injuring that nerve. And so it's worth it to have a slightly larger incision. If I don't know if you want to say something about this also, but if we look through historically at retrosigmoid surgery, looking back decades, there were lots of people with severe headaches, long-standing after this operation with acoustic neuroma surgery. It was a really big issue. I think not. I mean, certainly us, but high-volume centers who do a lot of these, I think, have figured out that you have to be careful in a lot of ways in doing this operation to avoid those really big headache problems. There is a little bit more muscle dissection, and I think patients do have a little bit more pain after surgery, kind of in the short run. So it may be a little bit more difficult recovery than translabyrinthine or middle fossa, but we really don't see those bad, horrible, long-standing headache problems in our practice. Frankly, maybe 2 decades ago, I used to see patients that were operated other places every once in a while with really horrible headache issues. I don't see that nearly as often as I did before. So I think other places are kind of catching up in terms of being careful with this. But it is a concern with this operation in terms of being careful because chronic horrible headaches is a bad outcome, even if everything else is perfect. You want anything else to say about the approaches? Again,
yeah, I don't think so. I just, we get a lot of questions about retrosig and headaches, and we're just not seeing the long-term headaches. There may be, as Dr. Schwartz was saying, maybe a little tougher to recover in the first few weeks after surgery, but in general, it seems like we're taking all the precautions necessary to minimize the longer-term headaches.
And again, I'm going to leave presenter mode so I can point again. This is just a very basic overview of the 3 approaches. So translabyrinthine is in front of the sigmoid sinus, through the mastoid, through the temporal bone. So we drill through the inner ear structures to get the tumor, but the tumor sits right here. We have a very direct view of the tumor. We don't have to retract any brain. And frankly, for a very small tumor, we often don't even look at the brain. It is hearing destructive, but gives us a great view of everything. We can see the facial nerve from one end to the other. Less risk to the brain, less problems with the soft tissue and recovery afterwards. Other than hearing, just a great approach. And we use that for anybody who comes to us with bad hearing for surgery, and anybody with a tumor that's large enough that we just say, we have really no chance of saving hearing. That's not really a goal of the operation, or we should focus on other things.
It does minimize potential effects of cerebellar retraction also, for large tumors.
This is the middle fossa approach, which is the temporal lobe. You can see here is the mastoid, and your ear would be out here. So we're looking down where the tumor is, between the cochlea and balance canals. This is the carotid artery, which we really never get close to. It's ghosted in on the skull here, but it's a small opening. So we open up the bone right here to see only very small tumors. You really don't have a good view of anything bigger than a small tumor. And when you try to treat larger tumors, it's going to increase risk to the facial nerve, which isn't really worth it. We have the best results for hearing with the middle fossa approach. But again, it's limited to patients with small tumors and good hearing. And the retrosigmoid approach, again, this is looking from behind in this direction with the cerebellum, in this case retracted, although we actually don't really ever use retractors to retract. We rely on gravity, giving us space to get to the tumor in this area. It's good, people use it for very large tumors. Frankly, we would prefer the translabyrinthine approach for large tumors because we think it's overall safer. And for a large tumor, we really don't have a chance of saving hearing. But for tumors that are too large for middle fossa surgery, still not that big. In people with good hearing, we use this operation when we try to save hearing. Obviously, the most likely not good outcome from acoustic neuroma surgery is losing hearing. It happens very frequently. But it gives us a view of these sort of smallish to medium-sized tumors. that have the right configuration in patients who have good hearing, although it can be used for larger tumors as well. Next issue, which is what's the approach in terms of how aggressive, I use the word aggressive, which is maybe it doesn't sound like the best word for surgery, but really is what it is. Do you go in with the goal of saying, we're going to get the whole tumor out no matter what? Or do you say, we're going to be super careful and just not really not be aggressive, be very passive and just take some of the tumor out?
I wouldn't mind making a comment about that because this is something we also see often, philosophical differences. Dr. Schwartz is very humble, but I have to say that it's very rare that we do a subtotal removal, even for large tumors. But to protect the facial nerve, for which we do have great outcomes, nobody's perfect. I believe what experience provides is that we do more often than not, if we can't take the whole tumor out because of size, then we do what's called a near total. The near total is a tiny scrap, often about as big as the pinky fingernail and as thick, which carries less than a 3% risk of coming back. We see a lot of places, and we have to do a lot of revision surgery when they do subtotals and consider radiation. I'm not a big fan of radiation for young people. So we would take a more, what I call cautiously aggressive approach in a young person and try to make this the last treatment they need. In other words, even though they have a scrap, it's devascularized, not likely to return or grow back, and not likely to require radiation.
Yeah, so what we put here is respect for the facial nerve and respect for the tumor. So back in the day, going back decades, let's say to the 70s and the 80s, if you're going to have surgery for an occlusal roma, the goal was going to be get the entire tumor out. Of course, even still trying to preserve the facial nerve, which was the goal going back to that time. Now, I think that obviously we understand that facial nerve injury is a really bad problem. That's something we want to avoid, and you have to respect the facial nerve. There are really three advances that allow us to not be super aggressive, to not say we're going to get the whole tumor out no matter what. First one is we have MRIs, so we can watch with MRIs what's happening and understand that the tumor is stable in size if we leave it, or if it grows. Because even though our experience is these very small pieces tend not to grow, that's not a guarantee, and sometimes they do. So we have MRIs, we can watch it. The second one is we do have radiosurgery. So if we leave a little bit of tumor and we do see it grow, we're not committing somebody to more surgery. We have another way of treating it rather than bringing them back and doing a second operation, which nobody really wants. And then the third issue is that we've watched many patients with MRIs after surgery for years and see that at least if the tumor that's left in place is very small, and this is especially true of translapian surgery, those small pieces of tumor tend not to grow. They tend to just sit there, and if anything, are more likely to shrink than to grow. So we have to respect the facial nerve, and we would much rather have a patient with a small white dot that we've got to watch with MRIs than have somebody with an MRI that looks perfect but a weak face. But respect for the tumor is you can't take that too far. So leaving very small pieces of tumor leads to very good results, but leaving big pieces of tumor does not. So bigger pieces of tumor will tend to grow back just like they were before. We're not sure exactly why that is, but we think it has to do with the vascular supply to the tumors. And the tiny little piece, we can cut off most of the blood supply or all the blood supply and change how it behaves. Whereas the big tumors still have the same blood supply, still have the same relationship with everything around them, and will grow. Second operations are definitely more difficult than first operations, and you have to respect the tumor and not think of it as something that it's going to be fine no matter what you do if you leave some behind, if you leave too much. Third thing is, what about hearing and cochlear nerve preservation? I think the question of preserving hearing when it's really not a feasible, realistic thing that's going to happen, or trying to preserve a cochlear nerve, even if you don't have to have hearing to preserve, is more problematic. Our facial nerve monitoring is very good, so we know what we're going to get when we do surgery. We monitor the facial nerve, we stimulate the nerve with electric current, we record the twitches of the muscles in the face, and it's real time, and it gives us excellent predictive idea of what's going to happen. Our hearing monitoring is not so reliable. So if we leave tumor for hearing, very often the patient will wake up without hearing anyway. We do use sometimes cochlear implants for patients who have no hearing and a cochlear nerve that's intact. But Rick, I mean, our experience is that only works for small tumors.
Yeah, I think that's true. There was a nice study from one of our colleagues in Italy showing that if tumors come out of the canal very far, that you're not likely able to preserve a functioning cochlear nerve for a cochlear implant. But we're in the process now, and we're putting together the manuscript of being able to test cochlear nerve integrity in the operating room. So currently what's happening is at most centers across the country, they're implanting cochlear implants when they think there's a possibility of it functioning, but it's sort of random. We don't know whether it's going to work, which is not a major deal. I mean, you don't have to wear the external device if it doesn't work. But we're working on trying to test cochlear nerve integrity so we have a better idea of whether or not we should put a cochlear implant in at the time of surgery and not waste the patient's time or, frankly, the medical expense. But yes, I would say one of the most recent sort of cutting edge treatment options is to try to preserve the cochlear nerve and put in a cochlear implant. At a very minimum, it's very helpful for tinnitus. And the maximum benefit would be, and we have, I think one of my happiest cochlear implant users is somebody that we did after a translab. They can be beneficial.
But I think our experience is, and I think the realistic thing to say about it is that for small tumors, we have really good results, and we think it's a very promising thing. But for bigger tumors, it's really not very realistic.
Right.
And the chances a cochlear implant is going to work is very small. And saying, oh, my philosophy or my goal here is we're going to preserve your cochlear nerve or preserve your hearing for a large tumor, that's just not realistic.
No.
Or even what we consider a medium-sized tumor, depending upon the configuration of the tumor and other details, it's still not really realistic. And if it means leaving a lot of tumor to do that, or promising something that's not possible, that's really not true.
Yeah.
All right. So this is what we're talking about. So this is one of our patients who obviously came with a giant tumor on the left.
Right.
Had normal facial nerve outcome after surgery, but we had to leave a little bit of tumor to preserve the facial nerve. It was just too stuffed. This graph that I'm showing, I didn't want to show like our tiniest one. This is kind of a big residual for us.
Yeah.
And frankly, this is one where the tumor did regrow and the patient needed radiation, which again is the minority of patients in our situation. So realistically speaking, this is one of our kind of what we're trying for. This is kind of the maximum that we are happy leaving. We want to make sure that it's a small amount of tumor. We want to make sure that the odds of it growing is probably very low, and we want to make sure that it's a small enough piece that if it does grow, nobody really has a thought to say, oh, that's too big for radiation. It's definitely something that can be radiated, and is not something that's going to force another operation. This is the opposite, which is a patient that we recently operated on somewhere else. Now, I don't have the scan from before the first operation, but it was a giant tumor, and the patient actually did well clinically from that operation. But there's still a lot of tumor left, and on the left you see the immediate post-op scan. But a few months later, you still got a lot of tumor left, and it's going to need more treatment, and this is going to force more surgery. Understand that when we talk about resecting tumor, And what we're really talking about is removing volume of tumor. So, so the amount of tumor you left, don't think of it as just a line, like a linear measurement. Think of it as the volume of the tumor. Volume is a third power. It's a cube power, right? It's the volume. And so to reduce a 3 centimeter tumor to 1 centimeter tumor, if you think about it as a volume, means taking out 26/27ths of the tumor.
Only Mark can do that great math.
Yeah, I mean it's 3 cubes and versus 1 cube, so it's 27 versus 1. So really, to leave that small pieces of tumor means taking out nearly all the tumor, and also to be fair to other surgeons and other places and everywhere, when you talk about volume, I mean, even going from 3 centimeters to 2 centimeters, again, it's a cube power. The patient might say, oh man, they hardly took anything out to go from 3 centimeters to 2 centimeters. That's still taking 2/3 of the tumor out, right? They go from 27, which is 3 cubed, down to 8, which is 2 cubed. That's still over 2/3 of the tumor. So you can take a lot of tumor out and still have a pretty, a measurement that seems like it wasn't that much. But it really means respecting not only the facial nerve, but also respecting the tumor.
Another thing, again, as Mark said, we inherited this case. This surgery was done elsewhere first, and then we revised it and were able to give this patient a near total. But you can see from the images that the initial surgery was a retrosigmoid, and this is a perfect indication now for us to go back, but come back translab, because this is a fresh plane that wasn't engaged by the first surgery.
Right.
And so we can avoid some of the issues with scarring that make sometimes these revision cases more problematic.
Right. So retrosigmoid is coming in this direction next to the cerebellum. Translab would be coming in this direction, right through the bone to get the tumor. And always going back a different way than the first operation, especially retrosigmoid first, translab second. That's much better than going back the same way twice.
Yeah.
So that was sort of the philosophy of what we do in surgery and how we handle it. But then the other issue is, what should patients expect both before and after surgery? I mean, you don't have to expect very much during surgery because you'll be asleep, but it's sort of before and after surgery. First point is, I mean, it's extremely rare for an acoustic neuroma to be an emergency. There are some exceptions. Somebody with a 5 centimeter tumor and hydrocephalus, that might be an emergency, but that's a tiny percentage of all patients that present, at least in the United States, with acoustic neuromas. So it is not an emergency almost always. We've even seen people who have hearing loss for many years just happen to get their hearing test in April, because they just said, now's a good time to go get it, and they get the hearing test. No other change besides some hearing loss. They get diagnosed with a large acoustic neuroma, and they're told that it has to be done right away. That's not true. I mean, there may be a few exceptions, but that's not true. If you think about if the reason you went to get evaluated was not because of really rapidly progressive symptoms, you happen to go because I thought about it in April instead of in December or in August or in last year or next year, that's not an emergency situation, and nobody should be telling you don't have the opportunity to think about things before treatment. Anybody who tells you differently is not right. Anybody with acoustic neuroma should have a full discussion of treatment options. For some patients, that means a true discussion of things that patient might do, and it comes close to what we call equipoise, which means, hey, it's reasonable to do surgery, it's reasonable to do radiation, it's reasonable to observe it. Sometimes the decision is very close to that point where all three of those meet. But even the patients who really surgery is the best option, you need to go over with the patient why it's the best option. Yes, in other patients, radiation may be the best option. In other patients, observation might be the best option. But why, in your case, is it why in your case is it that you have to have this particular treatment? You should have a general idea of what the philosophy of your treating center is, because every place is a little different. I think that patients come to us for surgery very frequently, and we have a bent in that direction. But we also have to have the philosophy of seeing the patient who's coming to us for a first opinion and thinking about every option and providing every option. Multiple opinions. Do you think that helps us or hurts us to say that, Rick?
I mean, I think you're entitled to multiple opinions. There's a huge difference in center experience, and I again, this is one of the tougher neurological and neurosurgical diagnoses, and surgery for the treatment of these tumors is delicate. It's like the Malcolm Gladwell's 10,000 hours. 10,000 hours of experience certainly helps. And then, of course, the importance of careful review of MRIs and providing as much information as possible. You should be able to ask your doctor how many they do a month, how many they do a year, how many have you done in your career. Those things are important. Yeah. And then, I guess I'll share, when we hosted the acoustic neuroma meeting more than a decade ago, one thing that Chris Sywick and I and Dr. Schwartz became aware of was just because we felt that a result was excellent, we saved hearing, or in a big tumor, we got it out and we protected the facial nerve. Patients had a new normal, and we had to address that new normal. And so we have created a program. This is pretty much all we do, Dr. Schwartz and I, as acoustic neuroma surgery and some meningioma surgery. But we've really created a program that we hope envelops the patient, because it's oftentimes people in the middle of their lives, healthy, have a little bit of hearing loss, suddenly are diagnosed with this, and it's frightening. And you need to seek out really comprehensive, holistic care. That's what I believe is important in the preoperative, intraoperative, and postoperative periods of your care.
Yeah, I would say there's actually kind of two red flags. The first one is when you see somebody who says, you don't need to talk to anybody else. Everybody should feel free to get as many opinions as they want. I will say, you do reach the point of diminishing returns at some point. When somebody gets to 8 or 10, you just start taking circles, and maybe that, but you should feel as many as you think you need is what you should get. The other one is when the surgeon says, oh, this will be easy.
Or it's an emergency.
Emergency we're an emergency. But the emergency, as I said before, but also, oh, this will be easy. You say, oh, we don't have to be aggressive. We can leave tumor, and don't worry about it. It's not going to be a hard operation. It's not the hardest operation in surgery. I mean, there are some other things that I think are probably more life-threatening or more challenging. But really, there's a lot to think about with acoustic neuroma surgery. It's not easy. It takes a lot of attention. It takes a lot of experience, and even you say, oh, small tumor might be easy. Well, small tumor, it's not as, the risks aren't as high. It's gonna be a faster operation. We're gonna get out faster, but the stakes are also high. I mean, it's if every little tiny thing matters, and patients really have to, it is a situation where you have a new normal, and where you do have hearing issues in most patients. The vestibular systems that aren't entirely normal, so the balance nerve is not entirely normal, but it's high stakes, and every little detail counts. The other thing I put here is importance of careful review of MRIs. I mean, I think that patients deserve their surgeons to really think about things and be careful. And I mean, I always ask for old MRIs. I mean, you don't want to rely on the radiology reports. You've got surgeons be looking at it themselves, Have good MRIs. If you need to ask for a better MRI, it's worth it. If you need for the patient to say, you say to the patient, listen, can you get your scan from last year, the year before to us? We really want to review everything. That's all worth it. You want as much information as possible. Good hearing tests. We generally don't do vestibular testing as a routine, but there are certain circumstances where it's helpful to the decision making. You want to have all the information that you need and have it be as good as possible.
Agreed. People also often ask about MRI volumetric versus non-volumetric measurements. There's really no data to suggest that a volumetric measurement changes anything. Really, all of the data and results are best prognosticated or determined or predicted by the greatest diameter of the tumor in whichever plane. So patients often ask that volumetric analysis is not critical. It's just measuring the greatest diameter.
Yeah, we use volumetrics for research, and then also for medical treatment when let's say neuropharmaceuticals, when they're using drugs and chemotherapy for some difficult tumors in a investigational way, they have to have volumetric measurement to tell what they're doing. But really, for decision making, whether to do surgery, whether to watch, how what's going on. There's no, volumetric measurements can be very misleading because a tiny change in volume might not be, a tiny change or something you can't even appreciate looking at an MRI or measuring out with lines could in a volumetric measurement show a significant difference, and people can get scared by that, even though it's not really clinically significant. And this is probably the biggest one, is what to expect after surgery, because there are a lot of issues after surgery, some of which are intrinsic to the nature of acoustic neuromas, some of which have to do with the surgery itself. Vestibular issues is first.
Yeah, I mean, most patients are dizzy after surgery because although when you enter surgery, your tumor has taken some of your balance function in that ear. When we take the tumor out, no matter which approach, and if it's done appropriately, you lose all residual balance function in that ear. So the brain has to take some time to compensate. And that, in my opinion, is really the primary brain issue. Spinal fluid leak, that's why we keep patients for a total of 10 days. We do our best to mitigate that possibility. Soft tissue issues are not often a problem. I mean, we don't see wound infections very often at all. Hearing issues, if a patient, we certainly consent. We make sure that our patients understand that their likely greatest risk when we're trying to save hearing is hearing loss. But, those are issues that we have to address, and we do. And then follow-up MRIs. So for our local patients, it's easy, but also for our patients that travel from out of town or out of the country, it's easy. We have telehealth. Patients upload their MRI scans, and we have video visits and go over and follow for life. We follow for life.
Yeah. Yeah, I would say that really the hardest part about recovery, probably 80 or 90% of it in most patients, is vestibular issues.
Yep.
So in taking a tumor out, you change the vestibular nerve, usually by cutting the nerve or taking the rest of it. Now, some people come to us with bad vestibular nerves already. The tumor is taking the vestibular nerve. Those patients have a pretty easy recovery. It's the minority, but we see it pretty frequently. But most patients have a sudden change in their balance nerve. The brain doesn't like that much, and they get very dizzy after surgery and have to recover from that and recover balance. Surgical approach doesn't matter. Aggressiveness of resection doesn't matter. That's just the nature of taking an acoustic neuroma out by any aspect, and that's most of it. Brain issues are a minor thing. I mean, you're having your brain operated on, so it's you have to recover a little bit. We're very careful with spinal fluid leak. Soft tissue issues, again, I think it's a little bit more with retrosigmoid, the least with translabyrinthine, middle fossa sort of in the middle. Hearing, MRI. Last issues.
Yeah, patients who travel. We have been doing this for over 2 decades together, so we have plenty of data to suggest. I mean, we have patients who come from out of the country and fly home safely. Often our patients, when they're in San Diego during the week that they're out of the hospital, hanging out. We have a facility on campus where they stay, and they often do tourist things in San Diego, go have lunch by the beach. I've had patients with big tumors go to the zoo with their kids. So traveling is not an issue because it's 10 days of your life for the rest of your life. And then lifelong care. We're absolutely committed to being in touch, uh, doing our best to call the same day you call, whether it's for a new consult or for a problem you're having or a concern. We tend to be on it, and you all deserve that because this is it's a journey. There's no question.
Right. And for patients who travel, really, I think the only person you'll need to see for care after returning home is a physical therapist.
Yep.
For most patients. That's it.
Yep.
We want to make sure we have contact with your regular doctor, and make sure that there's a line of communication, make sure if anything does happen, which again is rare but not impossible, we can help with managing that. But really, the only person you should expect to see is a physical therapist.
Yep. Okay, so thank you for listening, and I think we're going to take some questions.
All right, thank you, Dr. Schwartz and Dr. Friedman, for that presentation. We do have some questions that we'll get into now. You talked there at the end about what to expect post-surgery and what that recovery looks like. What does the timeline of kind of returning to everyday life and doing things like driving and kind of going back to the grocery store, maybe returning to work look like after surgery?
It's very difficult to predict on a patient by patient, patient to patient, and some people get back very quickly. Other people take a long time to get back. I think if in terms of, you mentioned two things, return to work, I think the biggest predictor of that is how motivated the patient is to get back to work. And I mean, this is a little bit of a joke, but I typically tell patients, I said it many times, if you've got your own business and you're losing money, you're going to be back even answering emails probably in the hospital, and you're going to get back really fast. If you work for the government, it's going to take 2 or 3 months. The other one you mentioned was driving, and again, everybody's different. We don't have to like report anybody to DMV for this. It's not that sort of situation, but I think your family member is going to be your driving instructor, and probably expect at least a few weeks. No exertion for a month, so mostly because of the risk of spinal fluid leak, we don't want people exerting or lifting anything heavy because that transiently increases the spinal fluid pressure in the head. But so we don't want people to exert themselves, but we want them as active as possible, walking, doing normal things. I mean, nobody needs nursing care, but also nobody is particularly useful for a few weeks after surgery. So you're not going to go home and take care of your family. You need somebody else to help with that for at least a few weeks after surgery.
Great. And with that initial recovery process, those first 10 days, does that differ based on the approach someone has for their surgery?
I think there, as Dr. Schwartz was saying, there's minimal soft tissue involvement in a translab. I would say the middle fossa is somewhere in between because patients get a little bit of what we call trismus, tight jaw, but that resolves over time. And the retrosigmoid approach, I think, historically would have been the most difficult perioperatively, but because of the approach that Dr. Schwartz takes to elevating those muscles, minimizing muscular incision, that's where patients get a lot of pain, and we don't do that so much. I would say probably the retrosig is a little bit more, little bit more of a difficult recovery. It's not difficult, but
I mean, the biggest issue is the vestibular.
Yeah.
And that's probably 80 or 90% of it. So it doesn't matter what the approach.
Right.
But I mean, I was just talking to Tamara, who's our PA, and our fellow, who said that they probably get a few more phone calls from retrosigmoid patients, for instance, in translabyrinthine patients, because it is a little bit harder and a little bit more neck pain. Again, I don't think there's going to be a difference in long-term outcome. People get over it over time, but there's a little bit harder recovery.
Yeah.
Great. For someone who has a small tumor that is stable, it's not showing growth signs, however, their symptoms are worsening, could surgery be used to help relieve those symptoms?
I would say the answer is it depends on the symptom.
Yeah.
We consider dizziness that is impacting one's life significantly enough an indication for surgery, irrespective of the growth rate or size of the tumor. And then I am a huge advocate for hearing preservation. So if a patient has a stable tumor, but their hearing is declining and they want to do something proactively, I think that that's an indication to help through either the middle fossa or the retrosigmoid approaches.
And I can think of three specific. I'd say in general the answer is probably no, but or maybe. I say in general the answer is maybe, but there are sort of 3 points. First one is some people are very disabled by dizziness, and we typically can help people by taking the tumor out and taking the rest of the balance nerve, and it doesn't create a normal situation, but it lets the brain compensate much better. But that's a severe problem. It's not a mild problem, maybe not even a moderate problem. That's severe. Second one is, this is not very common, is facial sensation and facial pain, and especially facial pain or trigeminal neuralgia pain. That person should have surgery if they have trigeminal neuralgia that's really not easily controlled medically. And then the third one, as Dr. Friedman talked about, was hearing. This is I would say maybe this is a patient choice issue because I don't know that everybody wants to put their hearing at the top of the list. But there are patients with small tumors stable, their hearing is getting worse, and they feel strongly that they want to do surgery to take the tumor out and give the opportunity the best option. I would never twist somebody's arm and say they should do it or have to do it, but if the patient feels that they want to do it, it's a good option.
Great. You mentioned about having long-term headaches after surgery and not seeing those as often anymore. But kind of what timeline, if someone is having those headaches, at what point should they start to get concerned that maybe they are going to have a longer variation of headache pain?
Yeah, there's a few answers to that. Back in the day, there were people who were absolutely disabled by headaches after retrosigmoid surgery, and nobody knows exactly why that was. It could be because the surgeons weren't careful with drilling the bone and leaving bone dust, because the only operation of the 3 that requires drilling a bone on the inside of the dura is the retrosigmoid. It could be because of how the muscles were closed. It could be because of the occipital nerve. It could be because of muscles attaching to the dura. But there were people that had absolutely horrible problems with headaches, and we don't see that anymore. There are some patients who have headaches after acoustic neuroma surgery. Oftentimes, these are patients who were headache prone before. Sometimes it's related to the incision, sometimes it's related to the occipital nerve, and sometimes if we have a plate in place, it's worth taking that out after 6 months or a year. People that have migraines, people have migraines, have a threshold for the migraine, and going through the operation might make those migraines more frequent or worse. So it's important to treat root causes of headaches, where the cause is not necessarily the tumors, the surgery, but the surgery makes things a little bit worse, and we want to make sure that's treated appropriately. The last thing I'll say is there is, when we look at headaches after surgery, the results at 2 years are a lot better than, the results at 2 years are excellent, whereas the results at 1 year are not quite as good as excellent. So it might be a year or two before things settle out in the worst case scenario.
Thankfully, it doesn't happen very often.
Yeah. Mm-hmm.
Right. You two talked about the cochlear implant, kind of that discussion in the manuscript you're working on. Is a cochlear implant an option after all 3 approaches, or is that eliminated with any of the approaches?
No, it's available with all 3 of the approaches. However, so one might think because we're going through the inner ear in a translab that you can't, but we don't take the cochlea out. And so cochlear implant in the translab is straightforward for the right patient. But obviously, if we're doing hearing preservation surgery, we would never do it concurrently, right? Because we need to take the tumor out, assess the patient's hearing when they're awake before they go home. But yes, if you can preserve the cochlear nerve through the retrosigmoid or middle fossa approach, that patient is potentially eligible for a cochlear implant. at a later date. But we also typically recommend that they consider it within 3 months of the surgery, because if you do lose your hearing in a hearing preservation approach, sometimes the cochlea can become fibrotic when it loses its blood supply, and you can't get a cochlear implant in.
Yeah. So, and again, it's really, I think that anybody who suggests that a cochlear implant is a realistic option for most patients with anything other than small tumors,
Yeah.
it's not correct. But for small tumors, we often save the cochlear nerve. The cochlear nerve looks good. With transimerthine, obviously the patient doesn't have hearing, but with the other approaches, even if you have a good cochlear implant, wake up without I mean, a good cochlear nerve, you wake up without good hearing, and you can go back with either retrosigmoid or a middle fossa later on in the first few months. Transimerthine, actually, the transimerthine approach, he puts you in exactly the right place for putting the cochlear implant in.
Yep.
It's very little additional work to put the cochlear implant in, so you can do it at the same time.
Yep.
All right, we have time for a couple more questions. We have a lot of new patients who are getting diagnosed younger, but we also have a lot of new patients coming to us being diagnosed later in life. So how old is too old for someone to go through a acoustic neuroma surgery?
I don't think it's age specific. I think it's medical condition specific. I have been forced to operate on several patients in their mid to late 80s because of large tumors or terrible symptoms. We had a really interesting case once a while back of a lady who had a large tumor, and it damaged the little nerve that's associated with taste. Because of the size, it had stretched the tumor. And because she wasn't tasting food, she wasn't eating, and she was dropping weight so rapidly, the family was terribly concerned. We took her to the operating room. We took out the tumor. Her taste recovered, and she was so happy. I got a gift of a huge box of food from her hometown. It was, yeah.
Yeah. My oldest patient is 94.
Yeah.
But that has to be a healthy 94-year-old, and it has to be a really good reason for surgery.
Exactly.
And I think it has more to do with general state of health,
Yeah.
Which is different in everybody, and kind of your biologic age as opposed to your chronological age.
Yeah.
Thank you. And the last question we have is from someone who is post-AN surgery, but they are curious if there's been any study on AN regrowth related to pregnancy. I think they're wondering if the pregnancy hormones might cause any kind of regrowth if they've had surgery already.
I don't believe there is data to suggest that acoustic neuroma are estrogen or progesterone sensitive, meaning I don't think the hormones themselves have an impact. However, when a woman is pregnant, especially during the third trimester, their fluid balance shifts and they take on a lot more fluid because they're supporting another life. And so just like face, arm, legs swell, tumors can swell. It's very rare that they would swell to a size that became emergent. But so I don't think it's growth per se. I think it's what we call extracellular fluid that probably resolves after delivery.
Great. Thank you. Well, Dr. Schwartz, Dr. Freeman, those are all the questions that we had. So we appreciate your time and sharing your expertise and for the partnership we've had now with UC San Diego for quite a few years. Thank you so much.
Thank
Thank
you.
you.